Well, my name's Brittany itself. I'm an occupational therapist and certified hand therapist. And today we're going to talk about the hand and wrist for the sports therapy residency. So we'll start with the metacarpals of the hand. So I like this picture over here, primarily because I think it helps us understand how we grasp. So if you're looking at the first, this is the thumb, index, long, ring, and small. And so you can see the joints and how they're depicted above the carpals. So when you make a fist and you see the fourth and fifth metacarpal, they'll actually flex forward about 20 degrees. That allows for your grip strength on your ulnar side of your hand, where your second and third are really stable joints above the carpals, and it allows for more fine motor manipulation. And then the first metacarpal, which is the thumb, articulates with the trapezium. The phalanges, we are going to talk about common injuries, but also the pulley system. So the PIP, which is the proximal interphalangeal joint, it has a volar plate on the bottom or on the palmar side. This one's commonly injured when a basketball hits the hand. The volar plate is to keep the PIP from hyperextending. So many times when a ball or you fall and you hit here, you'll hyperextend the volar plate. So to position that in this splint, you can see we do a 30-degree PIP flexion angle to allow the pulley to kind of close down so it can heal for a couple weeks before we start motion. So here you can see where the volar plate has been disrupted in this picture. The DIP, distal interphalangeal joint, also has a volar plate, and so does the MCP. The most common one to be injured is the PIP. And then when we are referring to the phalanx, we talk about it as P1, P2, P3. So a lot of times in a doctor's note, you'll see P1, P2, P3 referring to proximal, middle, and distal phalanx. The thumb is a little bit different. It contains 2 sesamoid bones in its volar plate at the NP joint, and that creates a trough for the FPL to run through. So the flexor pollicis longus travels through the carpal tunnel and then kind of turns and goes to flex the IP of the thumb. The thumb also has an extensor hood, and common injuries of the thumb, the ulnar collateral ligament injuries. We call them different things, but they're all essentially the same thing. So a skier's thumb would be an acute injury to the UCL of the thumb on the NP side. So the NP joint, ulnar side, that's where it was quickly jerked. Most of the time you put that in a splint. At gamekeepers, it refers to the same injury. It's just been due to degenerative changes over time. And then the sternal lesion is a complete disruption, and that one requires surgical treatment. Ligaments of the thumb, the main one of the CMC is the anterior oblique ligament. They also refer to it as a beak ligament that stabilizes the CMC. So, and then the strongest stabilizers are the palmar oblique and the dorsoradial ligament. The MCP joint, so this is your digits 2 through 5. So here you see the collateral ligament. The important part about this ligament is that's the reason that we splint hands at 60 to 70 degrees of flexion is because when your fingers are straight, the collateral is shortened position, and then when you flex to the 60 or 70 degrees, it's in an elongated position, so that when someone comes out of a splint, they're able to flex their IPs without the tightness of the collateral ligament. This is the dorsal hood or the extensor apparatus the dorsal hood or the extensor apparatus. So there's a video, I won't watch the whole thing, but just for your um, benefit, you can go back. Can you see that? How do I show you that?
We're only sharing the PowerPoint.
Okay. Anyway, there's a video that talks about the dorsal apparatus.
We can have it watched if you want.
Yeah. It just makes more sense than me talking about it. Okay, how do I get back to my PowerPoint? Here. Okay. So when you're doing the visual inspection of the hand and you're looking at the metacarpals and the appendix together, you're looking at the attitude of the hand, is what we call it. So a normal digit cascade. So when you look at your hand, your finger should stagger with your index finger all the way down to small. And we call that the cascade. So if you're looking at a hand and there's a finger going the other way, that's not a normal cascade, and there's probably something wrong with it. All fingers will flex naturally towards the scaphoid tuberosity, as you can see here. So a lot of times kids will come out of, or patients will come out of a cast and they'll go to make a fist and their finger will kind of overlap and they'll be concerned with that their finger's going in the wrong direction. That's not necessarily true as long as you can line from the fingernail to the scaphoid tuberosity and is moving in the correct direction. Maybe it's just limited by its range of motion. Other important visual inspections of the hand are the longitudinal, distal, transverse, and palmar transverse arches. If the hand does not have these arches, it can be because of nerve damage to the hand or weakened hands or muscle atrophy in the intrinsics. So the longitudinal arch runs through the center of the hand, through the third metacarpal to the distal phalanx of the third digit. The distal transverse arch is the arch, it's easier to see here, across the heads of the metacarpals, and then the proximal is across the base of the metacarpals. It should arch to create kind of a cup in your hand. Common splints used for various fractures. We have most common metacarpal fracture is probably the boxer's fracture, which is the fifth metacarpal. We, depending on the age population, depends on or where the fracture is. So a boxer's fracture is at the head of the metacarpal, but if there was a fracture that was at the base of the metacarpal, you may choose to do a forearm-based splint versus a hand-based splint. Also in the pediatric population, we typically go with a forearm versus hand-based. So it's really, that depends on the doctor. So these over here are forearm-based radial and ulnar gutters, and these are hand-based ulnar. Ulnar and radial gutters. So with proximal and middle phalanx fractures, sometimes we leave the eyepiece out, not necessarily in the pediatric population because we want to protect them as much as possible. So almost every splint we make for them includes the eyepiece. One of these two, three. But in the adult population or an older population, you may leave the eyepiece free to allow for FDP, flexor digitorum profundus and flexor digitorum superficialis to move, because in an adult, the PIP will get really stiff. And again, talking about that 60 to 70 degrees of MCP flexion to protect those collateral ligaments to prevent tightness. A tough fracture, so a fracture of the distal phalanx, you just do a little tip protector. So these are hand-based and forearm-based spica. So this would be like your skier's thumb, gamekeeper's thumb, scaphoid fracture, would go into a forearm-based thumb spica. So the intrinsic muscles of the hands, there are 4 compartments. You have the thenar compartment, and it contains the abductor pollicis brevis, adductor pollicis, flexor pollicis brevis, and opponens pollicis, the deepest head of that one. So that is your thumb compartment. So this section is your thenar compartment. Your hypothenar compartment is on your small side, small finger side. So it includes abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. And then the central compartment includes all 4 lumbricals. And then the adductor interossei compartment includes the interossei muscles and the adductor pollicis. And we'll talk about what they do. So these are important positions to be aware of and think about what muscles are being activated in these positions. You have your intrinsic plus position, which many times when you're getting an order for a split, they'll ask that you put them in that intrinsic plus position, which is the MCP's flexed and the IP's extended. That motion comes from the lumbricals. So the lumbricals' job is to flex the MCP and extend the IPs. You also have activation of the dorsal interossei because I keep up with it this way. So if you're looking here, palmar, ad, and dorsal dab. So you're thinking the palmar side, adduct the hand, and the dorsal side, abducts the finger. So what that means is on the palmar side, you're getting finger adduction, and the dorsal interossei, you're getting abduction. So when you create this intrinsic plus, you're getting the activation of the dorsal interossei adding, and then the lumbricals going into the MCP flexion with IP extension. If you see a hand that looks like this, that's an intrinsic minus position. That is likely due to a degenerative disease of some sort, or just atrophy of the intrinsics. So when we're referring to injuries to the flexor tendons, we break that down into zones. So the zones can be seen here. The thumbs have a zone of their own, but I'm talking just in general about the digits for now. So zone 1 will contain just the FDP, so the flexor digitorum profundus, and we refer to that as a jersey finger. So most of the time when you see a jersey finger, someone will make a fist, but their finger will, you'll be unable to flex the DIP. It's caused from being caught in a jersey or something like that, where it kind of gets twisted and ruptures the FDP. Zone 2 is known as no man's land. It contains both FDS and FDP. You can either cut one, both, partially cut one, full rupture, depends. Many times with a rupture or a laceration to zone 2, it will also lacerate a digital nerve, which is most commonly repaired, and you'll have numbness and tingling along the sides of the finger. It usually feels really well. Zone 3 is in the palm of the hand. Zone 4 contains over the carpal tunnel, which has 10 structures in it. So all or a part of them can be lacerated. And then zone 5 is from the carpal tunnel to the forearm. Talking a little more in depth about the pulley system. The pulleys are important because they keep the flexor tendons from bowstringing. There are 5 annular ligaments. So the annular ligaments are these larger bands. And the most important are A2, so this one, and A4, this one. Mainly because they're the larger one. This is on your proximal phalanx. This one is most involved with rock climbers. And then the cruciate ligaments are the X-shaped, and there are 3 on each finger there. So common flexor tendon injuries. the zone 1. That's the one probably most commonly seen in sports. The trigger finger is a nodule on the flexor tendon, and the nodule just basically becomes too large to fit under the pulley, so it will get caught and trigger. This either requires a injection, sometimes surgery, sometimes it can be helped by just doing a small splint at nighttime to prevent sustained finger flexion. It can be congenital, so we'll see this in children in their thumbs from birth. It can also be acquired, so lots of repetitive gripping, lifting, weightlifting, things like that. Oops. And then tendon lacerations. So tendon gliding, we do a lot of tendon gliding, especially when people come out of a cast. The reason we do that is because in your fingers, you don't actually have any bone, any muscles in your fingers. They're all extrinsic, meaning that they originate outside of the fingers in the forearm. And so to make sure we're moving each one of them to their max potential, we do the sequence of tendon glides. So the hook fist is actually this one. So in this position, you're here, and that is considered max differential gliding between the FDS and the FDP. So the FDS starts in the forearm, goes through the carpal tunnel, and all the way to the end of the DIP. So that's flexor digitorum profundus. FDS will go same trail, but it will split. So I always think of split for the FDS, on either side of the PIP joint to flex there. So when you're doing your hook fist, that's the most FDS and the most FDP you can have. So your straight fist, you go the intrinsic plus and down. So the FDS is activated here, and that's the maximum glide that the FDS has just alone by itself. The max FDP glide would be the full fist, where the fingers are tucked. And I always tell people you'll know you have a full fist when the palms of your fingers touch the crease in your hand. So the distal palmar crease shows that you have a full fist. Intrinsic tightness versus extrinsic tightness. So sometimes you'll get a hand, and depending on how it presents, depends on which muscles you want to stretch. So if they go into a hook fist and it looks like this, their intrinsics are tight because they cannot get here. So these are shortened pulling here. So you would want to stretch intrinsics. If the extrinsic muscles are tight, they can get here easily, but they can't fully pull here. So their extrinsic muscles will be tight. So you would want to stretch maybe a full fist and wrist flexion to target the extrinsic muscles versus the intrinsic muscles. So differentiating between the two of them can help you understand why they're not making a full fist. And then this is a depiction of all the flexor muscles. So we already talked about FPL. So FPL comes here and goes to the tip of the thumb for the IP. And then you have your FDS that travels through your carpal tunnel. And here you can see where it splits to your PIP. Deep to the FDS is the FDP. So pollicis longus. Flexor flexor digitorum profundus. So here, and then it's below the FDS as it travels through. So now talking about the extrinsic extensor tendons. So the extensor tendons are categorized by the 6 different compartments. And so I like this picture because it gives you a nice view of what runs through, or which tendons run through each tendon sheath or compartment. The anatomical snuff box is here, so this triangular space. It's important for different palpation reasons. You can feel the scaphoid at the floor. The abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus create the triangle around it, and it also contains the radial artery and superficial branch of the radial nerve. So I broke it down into compartments. So your first compartment, if you're looking here, will be on your radial side. So this one is by your thumb. So on the hand, it would be here. It contains extensor pollicis brevis and abductor pollicis longus, and the common diagnosis associated is de Quervain's veins. So for de Quervain's veins, we typically do a forearm-based thumb spica. Your IP can be free in your thumb because the FPL and the EPL, flexor pollicis longus and extensor pollicis longus are not involved. So that tendon can glide freely and not affect de Quervain's veins. So these tendons. Extensor compartment 2 contains ECRB, ECRL, and it is separated from compartment 3 by Lister's tubercle. So here, these are your wrist extensors. This little point is Lister's tubercle, and this is your EPL. So you can see here, this tendon, this is your EPL. And it's important because sometimes following a distal radius fracture, the EPL can be ruptured. And that goes unseen sometimes because people think there's just not motion of the thumb, but sometimes it can be completely ruptured. So here you can see Lister's tubercle at the end of the radius, and this is EPL that kind of takes a little turn around that bone and up to extend the IP of the thumb. Compartment 4 contains extensor digitorum communis. So that's its job is to extend your MPs or MCPs. And then extensor indices. Compartment 5, digiti minimi, and compartment 6 is another important one for ulnar-sided pain. Common diagnosis from the ECU are ECU tendonitis or subluxation of the ECU that can be caused from tear in the ECU sheath. So just like flexor tendons, we have extensor tendon injury zones. Zone 1, if injured here, the terminal extensor tendon results in a mallet finger. Zone 2, zone 3 is the central slip. So here, and that results in a boutonniere deformity. Zone 2 doesn't really give you deformity. Zone 4 and zone 5 would be here. So a sagittal band rupture. So these can occur kind of commonly. I had a patient one time, he went to catch a baby because the baby was falling, and his finger was kind of jerked this way. He was young, and it ruptured his sagittal band. So the sagittal band keeps the extensor tendon from going off the side of the metacarpal, so it keeps it in line. So these are the common deformities. So your boutonniere is disruption to the central band or central slip over PIP will result in a boutonniere deformity, which will be flexion of the PIP and hyperextension of the DIP. The mallet finger is disruption to the terminal extensor tendon to the DIPs, so here. And then swan neck deformity can be volar plate, but can also be developed following a mallet finger injury because of the imbalance between the lateral bands and the terminal tendon. The lateral bands will shift up, making the PIP joint shift down. And then you'll create this swan neck deformity. Secondary. You can also have what's called a pseudo boutonniere deformity, and that is a deformity that takes on this position, but it's not due to the central slip rupture. So these are common splints that we use. So these are all various mallet finger splints. I typically use this one. In the pediatric population, we will do a splint and then we'll cast over the splint. In the adult population, typically they only do the splint, but they're advised to wash their hand, perform all hygiene without letting the DIP drop, because as soon as the DIP drops, even just a little, you have lost all scar tissue and you return to the lag. So you're starting over. So it's an additional 8 weeks. So the cast is kind of a good idea. So these are oval 8 splints. You can put them this way. That helps with the swan neck deformity, or you can flip them the other way. You can also flip them on the side to help with if the fingers deviated one way or another. So we typically do this for a boutonniere deformity. So let's go back and look at the boutonniere really quick. So here you can see that the lateral bands have just shifted down, and now they're pulling this into extension. So we want to do the opposite of that. So with this splint, we can bring the PIP down, bring the lateral bands back into place, and then the ligaments on the side here will realign for the DIP. And this is considered a dynamic L&B. So if you had a contracture, a flexion contracture of the PIP, this provides a 3-point stretch to the PIP to try to increase the extension. So a view of all the extensor tendons, and then you have, these are your EDCs, and then you have your juncture tendon between. So this histology of the hand, the skin is important when you're thinking about swelling in the hands. I'm always looking for wrist wrinkles or finger wrinkles. The hand can hold swelling up to a year following a distal radius fracture in the average adult. So it's always nice to compare the wrinkles between the fingers and the wrist creases. The skin on the dorsal side of the hand is typically loose and mobile. The palmar side is thick and less mobile, with more thick fatty tissue for grasp. And then there's fascia throughout the entire upper extremity. The fascia is very important when it comes to the gliding of the peripheral nerves. So the palmar aponeurosis is here. So the palmar aponeurosis is just really thick in the palm of the hand, and it's very common that there's a disease in the palmar aponeurosis called Dupuytren's. So you'll develop Dupuytren's contracture. It's typically seen in an older population, but it will develop nodules and pull the fingers down. Not like a trigger finger, because you can't stretch it out. Osteoarthritis of the hands is another common kind of injury to see. Not really injury though. Let's cut that part. Not injury. You have Herbert's nodes, which are at the DIP, and Bouchard's nodes at the PIP. We teach joint protection and activity modification, also various types of splinting. It's also important to keep the muscles strong, especially the interossei muscles and the thenar compartment. That helps stabilize the CMC. So, peripheral nerve considerations. So this is a lot, and I'm not going to talk about all of it, but it is all here for you. So I'm going to talk about how I treat it. So with the median nerve, everybody thinks about carpal tunnel, but the median nerve also starts prior to the hand. So it innervates the pronator teres, the SVR, palmaris longus, if you have one, and the four heads of the FDS. So one thing I didn't mention is flexor digitorum superficialis, so FDS. the one that goes to the PIP and flexes, it shares the same muscle belly. Whereas FDP, flexor digitorum profundus, has separate muscle bellies. The FDS is all innervated by the median nerve. Whereas the FDP depends on if you're on the radial side or the ulnar side for nerve innervation. So as the median nerve comes down, it innervates pronator arteries, FCR, palmaris longus, and the FDS. Then it branches into the anterior interosseous nerve to innervate the FDP to the index and long, the FPL, and pronator quadratus. There's a palmar cutaneous branch, which is purely sensory as well. So here, this is where it passes the carpal tunnel. So in the carpal tunnel, you have 10 structures. You have 4 FDS, 4 FDP, the FPL, and the median nerve. So as it passes through the carpal tunnel, you have recurrent branches that feeds the thenar compartment, which is abductor pollicis brevis, appotens pollicis, superficialis head, or superficial head of the flexor pollicis brevis. Then you have digital branches that innervate the first and second lumbrical. So that's important because it depends on when you're treating the hand and the upper extremity, you'll start to notice Snell's signs. So you can tap along the nerve, and that kind of helps you get a sense of at what area the nerve is compressed into the hand. So if you're tapping, and they start having a Snell's over the carpal tunnel, then you know you're probably not going to have to work on FCR because that's higher than the level of the carpal tunnel. But you will probably have to work on strength of the thenar compartment in the first and second lumbricals. Signs of anterior interosseous nerve. So as it branches off, you'll see the sign of Benedict or the benediction sign and the OK sign. So the reason this happens is because if we go back here and look at what the anterior interosseous nerve innervates, it innervates the FDP, so the flexor digitorum profundus to the index and long, meaning its job, this one and this one. So if this is not working and this is not working, and then your FPL is not working, so this is not working. When you go to make a fist, you can flex at your FDS, but you can't get your FDP, and you can't get your FPL. So you'll be able to move this, but you'll kind of have this sign. Then when you go to make your OK, rather than it being a circle, it'll be more of a teardrop. It's really more like this. So those are signs of anterior interosseous nerve syndrome. And if you ever see that or suspect that something's going on with that, I would definitely send them to the doctor because they need to work on those muscles. As the nerve reinnervates, you work on that muscle as it returns because that will affect the ability to hold their toothbrush, their pencils, do buttons, all their ADLs. So then talking about the ulnar nerve. The ulnar nerve is common in baseball players, musicians. So the ulnar nerve travels through the cubital tunnel between the heads of the FCU. So the cubital tunnel can be palpated here. You can kind of feel the groove. If you hit your funny bone, that's cubital tunnel. So the motor innervation for that prior to reaching the hand is your flexor carpi ulnaris, your FDP to your ring and small finger, because remember, FDP has its own muscle bellies and is innervated by 2 different nerves. There's a palmar and a dorsal cutaneous branch. So that will give you the sensation on the dorsal side of the hand and palmar side of the hand for the small finger and 1/2 of the ring finger. The other half of the ring finger goes on the dorsal side to the radial nerve and the palmar side to the median nerve. So the ulnar supply to the hand. So as the ulnar nerve passes through Dion's canal, which is in the hook hammock, it goes in to the hypothenar, and it innervates adductor digiti minimi, opponents digiti minimi, flexor digiti minimi, and the third and fourth lumbricals. So I put here, which you'll see, but when the lumbricals are affected on the third and fourth, you'll start to get an ulnar clawing. So you'll hyperextend at the MP. So if you think about, we had our intrinsic plus position, and then we had our intrinsic minus position. So if the full hand is affected, all the lumbricals and all the interossei are affected. But if it's only the ulnar nerve, then your lumbrical 3 and 4 and your palmar dorsal interossei on the ulnar side, you'll only have clawing of the last 2 fingers. And then you have Wartenberg's sign, which is where your interossei are not working, and you cannot pull in your small finger. So you cannot adduct your small finger. Another test is the Froment sign, which is atrophy of the flexor pollicis brevis. So this is the Wartenberg's, this is a clawing, and this is a Froment's. So this would be normal, and this is positive because the reason it's positive is the flexor pollicis brevis is not activating. So the flexor pollicis longus, which is innervated by the median nerve, is taking over. So then you'll get the flexion of the thumb IP rather than the hinge. Does that make sense? Okay. The radial nerve supply. So the radial nerve prior to crossing the elbow innervates the triceps, all 3 heads, anconis, brachioradialis, and the extensor radialis longus. Once it crosses the elbow, it divides into the posterior interosseous nerve, which is the motor function, and then it also has a superficial branch, which is the sensory function. So the sensory innervates the dorsal side of the hand. And then the posterior interosseous nerve returns in this quarter. So if you have a patient that has what they call Saturday night palsy, or has an injury to their humerus and it affects the radial nerve, they may have wrist drop. So this is wrist drop. And so if you're treating wrist drop, you will start by checking to see, do they have ECRL? Do they have function of ECRB? Are they able to supinate? And if they are, then maybe you do strengthen all of these, but then maybe they're unable to extend their MPs. So then you will start here at EDC and work your way down, strengthening each one as the muscle function returns. So the last one typically to come back is the isolated IP extension or index finger extension. So testing for nerve function, I use the Sims-Weinstein. So the monofilaments, so that's this one here. The normal sensation, you should be able to feel a hair between your fingers. Diminished light touch means you won't feel the little hair between your fingers. And once you get to loss of protective sensation, you can no longer detect when your hand is moving or your whatever part is moving towards something hot or something that may get you hurt. 2-point discrimination. Normal test is between 2 and 5 millimeters. So you'll press on the pulp of the finger and say 2 points or 1. They must be accurate. 7 out of 10 trials to give them a score. You can also do moving 2-point discrimination. Static 2-point discrimination just measures a different cell from the moving 2-point discrimination. And then you have the provocative testing, Tenel's test, and the Feynman's test. So if I have a patient who has AIN palsy. I will do the canals testing down the median nerve and then measure from a landmark to where the positive canals is. And that's how I can measure whether the nerve is returning in function. It'll repair a millimeter a day, an inch a month. Okay. Any questions about the hand or fingers? Okay. So moving on to the wrist. Talk about the carpals first. Probably the most important, well, not the most important, but the most injured that you'll probably see the most is the scaphoid. So it's part of the proximal carpal row. It's long with a narrow waist and it has very little blood supply. So you can see that the blood enters through the top of the bone. And so all of this blood supply has to go all the way through to the bottom portion of this bone. So if you have a fracture here or a fracture here, all of this blood supplies this bone. So you can see it better here. So that's why it's so important that they stay in a cast and they fully heal that scaphoid bone. If you have a swoosh injury where you're falling, it's recommended that 3 weeks following the injury is when you x-ray for the scaphoid because sometimes it's too swollen to be able to see the fracture in the scaphoid.
So do providers typically just go ahead and splint it just because that, like before the 3 weeks?
It depends. It depends on which one, but yeah, probably, and then have them come in for a follow-up. So anytime there's pain in that snuff box, so this area here is where you're going to feel that scaphoid and you can palpate it. If there's pain in that area, it's probably a good idea to get it x-rayed just to rule out the scaphoid injury just because of the blood supply. Because if there is a fracture and you're continuously moving, so as you flex your wrist, your scaphoid flexes. If you continuously put pressure and it does not allow the blood to go all the way throughout the carpal bone, it can turn necrotic and die and have to be removed. Other carpal bones in the proximal row is the lunate, the triquetrum, and the pisiform. So the lunate is another bone that can develop necrosis. Kienbock's disease, what that's called. And sometimes they will remove a whole proximal row. So if the Kienbock's disease is bad enough, you can see here that this would be Kienbock's disease. They could remove just that bone or they can remove a whole proximal row. And then precautions on that is you can never go into like a push-up position or your wrist hyperextended for the rest of your life with that one. The lunate is the most frequently dislocated carpal bone, and that's because of the structure of the ligaments within the carpals. When you fall, there's a little hole kind of in the wrist ligaments, and it will kind of pop out.
When they remove a carpal bone, do they replace it with metal or something and just leave it?
No, they usually just take it out. There are different ones that they can do. So you can do like where it's removed and it almost looks, they have an internal bracing, a four-corner fusion. They'll do that sometimes. It just depends. So the distal carpal row, you have your hamate, your hook of hamate. So your flexor retinaculum is the top of your carpal tunnel. So it's covered by that retinaculum, and that attaches to the hook of hamate here. Your capitate is your largest bone, or your largest carpal bone. The trapezoid is your most stable, and then your trapezium is at the base of the thumb. So you were asking about removing. So when people have CMC arthritis, the metacarpal sits on top of the trapezium, or the trapezium. and many times it will be necrotic, and so they will remove that. And I did have a picture in here. I guess I took it out. They'll remove it and they take a tendon, they take your FCR or if you have an FPL, and they will fill the space with the tendon and create a joint replacement for a thumb. So they can remove it for different ones.
And I've heard you a couple of times saying if you have it, some people don't have.
Right. So palmaris longus. So the way you check is you put your thumb and your small finger together and apply pressure and flex your wrist. If you have a tendon pop out, like I have one. I have one here. So that tendon that pops out is your flexor pollicis longus, but many people don't have one. It's good to have one. Yes. Also, 20% of the population don't have an FDS to the small finger. Okay, so this is overwhelming, but I thought it was important for you to have. So this talks about what each row does with a wrist motion. So this is something I go back and look at because it's too much for my brain to wrap around. So what it means is as your wrist flexes, the proximal row will flex, radial deviate, or the proximal row will go into flexion, radial deviation, and pronation, while the distal row moves into flexion, ulnar deviation, and supination. So they kind of rock. As it extends, the proximal row will extend, ulnarly deviate, supinate, and the distal row will extend, radial deviate, and pronate. So this is something you'll just have to look at and kind of wrap your head around. I watch a lot of videos and it makes sense when you watch the videos, but that just kind of gives you an idea of what the rows are doing through the motions of the wrist. Common diagnoses involving the wrist are ganglion cysts. We see these a lot in gymnasts, tumbling. Young girls get these a lot. They can be removed, they can be drained, they can go into a splint just to rest. Gymnast wrist is overused in the wrist, so you can see here where the physis starts to fill in prematurely. And then carpal bossing is here, so it'll be a bony growth on the dorsal side of the second, third metacarpal bones at the base. This is common for gymnastics as well. And then the key box, avascular necrosis of the lunate. One more thing, just to mention it before we go any further, is a scapholunate injury. So we talked about the scaphoid needs to flex. So you have your scaphoid lunate triquetrum. So if you have ligaments between each one, so as scaphoid flexes, it's tied to lunate, so lunate will go with it, and then triquetrum will kind of extend. So if there's disruption to the scapholunate, the scaphoid will flex and the lunate will extend with triquetrum. So this is abnormal. If there is damage to the lunotriquetral ligament, the scaphoid's going to flex, so lunate's going to go with it. But if there's damage here, the triquetrum is going to extend without that little bit of connection here. So that's important when we go to the dissociative patterns of the wrist. So you have carpal instability, dissociative patterns, and then you have carpal instability, non-dissociative patterns. So, these are the carpal instability dissociative is in the same row. So that would be your scapholunate injury or your lunate triquetral ligament disruption. So they create a dizzy or a busy pattern. So if we're talking about that and we're talking about scaphoid lunate triquetrum, as the scaphoid flexes, the lunate should go with it. If there's a disruption, it won't. The lunate will extend and the scaphoid will flex. That creates the dizzy pattern. Does that make sense? And the opposite of that would be the Visi pattern. So dorsal versus volar. If there is an association between lunate and triquetrum, as the scaphoid or the lunate will follow the scaphoid into flexion and the triquetrum will extend. And then this is instability. So this would be that four-corner fusion I was talking about. So this would be instability between the rows or the proximal row and the radius. And most of the time, this is a surgical problem. So the proximal row corpectomy. Oh, you can't see it, but you can see that they've taken the proximal row out here. So again, it's functional, but any push-ups you would have to do would be in neutral. You can never push up from a chair again. You just can't do anything with wrist extension. The four-corner fusion is typically done as kind of a salvage procedure if there's arthritis and things like that. This really, as you can imagine, will limit your wrist flexion and extension. So the goal with something of this is just to be pain-free and as functional as possible. Okay, so when I'm treating, say, let's use a scapholunate, for example. So say there is a scapholunate injury. I want to think about what is friendly to the scapholunate. So what is friendly to that is your ECRB, ECRL, abductor pollicis longus, and flexor carpi ulnaris. So what that means is if I strengthen these muscles, it's not going to pull and put tension on the scapholunate interval. So it's safe for me to strengthen those in the initial phase. It's so basically dart throwers. So when you do your dart throwers motion, that's a safe motion for your scaphoid lunate interval. So you'll strengthen things around that. So that makes sense. So your ECRB, ECRL, and your SCU, and your abductor pollicis longus. Unfriendly are the ones not checked. So your ECU, so you want to keep it friendly. So this is friendly. So going this way would be relatively unfriendly to the scapholunate interval, as well as this way. So this, is just a nice little chart just to refer to if you have any concern over what you should be strengthening with those interval disruptions. All right. So radiocarpal joint. These are just the connections between the carpals and the radius and ulna. But what I really want to talk about is the TFCC. Okay, so right here we talked about lunate being the easiest carpal bone to dislocate. So this is the spot right here that's open. You see how that circle is formed here? What do they call it? Space of Poirier. So that's what this area is called, and that is where the lunate will dislocate from. So your distal radio-ulnar joint, it's really important for that joint to be strong. Lost my train of thought. Okay, so with your distal radial ulnar joint, things you're thinking about is what does the radius look like in relation to the ulna? So you want to have that 15 to 20 degrees slope. So prior to any type of injury, most people will have that slope. Some people are born with a ulnar positive variance, so it'll be a little more shallow. Most people who have this type of structure will have a lot of pain on the ulnar side, whether it be TFCC or ECU, ulnar abutment syndrome. There can also be an ulnar negative. So this allows for too much space here, and you can see the DRUJ is not in alignment. So, the doctor will make sure that that slope is there for you, and they will let you know whether or not it's in the correct position. So the TFCC. So you have your distal radial ulnar joint here, and it's a part of the TFCC. So the triangular fibrocartilage complex is more than just one thing. So most of the time, what they're referring to is this articular disc that is similar to the meniscus of the knee. It absorbs shock, but there's a lot more involved in it too. It contains the sheath of the ECU. It contains dorsal and volar. Let's see. Yeah, the dorsal radial ulnar ligament here, and then there's one on the other side, the palmar radial ulnar ligament, that are stabilizing structures here, or they call it volar here. And then you'll have your UCL of your wrist is a part of it. The ECU and the ECU sheath is also a part of the triangular, the TFCC. Most of the time when they talk about the injury, though, they're talking about a tear to the articular disc. You can check for a disruption of the DRUJ piano key sign, and when you're treating the TFCC, you really just want a nice, strong, stable DRUJ. With weight bearing, 80% of your force is going through your radius and 20% through your ulna, unless you have that ulnar variance, and then it changes. So with the TFCC, many times you'll see people use a wrist widget. What the wrist widget is doing is just securing that DRUJ. They just want a really strong connection here, and that helps with weight bearing. Okay.